I'm Debarghya Sarkar. I'm currently a postdoctoral research fellow at Harvard University and Massachusetts General Hospital. And today's panel discussion is on discussing avenues for a medical student, specifically those who are pursuing their medical career, starting their medical career in India, doing their MBBS in India, and what are the avenues that could be pursued from there. So we have with us three panelists. We have Professor Saikat Mukhopadhyay. So Professor Saikat Mukhopadhyay is a JBNSTS scholar of the 1992 batch. He is currently a W.W. Karath Junior Scholar and an assistant professor in biomedical research at UT Southwestern Medical Center. And he did his MBBS from Medical College, Kolkata, his MD from biochemistry from Benares Hindu University, his PhD in biology from Brandeis University, USA, and his postdoc was at Genentech, also in the USA. Briefly, his current focus of research is to understand mechanisms of cellular signaling at the level of the primary cilia and its relevance to human health and disease. And we are sure Professor Mukhopadhyay will be discussing more about that during our discussion. We have our another panelist, Dr. Tamonud Modak. Dr. Modak is a JBNSTS scholar of the 2008 batch. He is a senior research officer at the National Drug Dependence Center of AIIMS, New Delhi. He did his MBBS from Medical College, Kolkata, his MD in psychiatry and drug dependence treatment from AIIMS, New Delhi, and also his PhD from the same place. So his current focus of research, as you might already guess, is in psychiatry and addiction. And we'll hear more about him too with time.
Hi.
Hello.
Hi, everyone.
The third panelist is Dr. Ananya Sengupta. She is a JBNSTS scholar of the 2006 batch. She's a senior resident of neurology at VMMC and Safdarjung Hospital, New Delhi. She did her MBBS from Neelratan Sarkar Medical College and her MD in general medicine from Medical College, Kolkata. And previous to the current position, she was affiliated to the stroke unit at the Department of Neurology in AMRI Hospital, Kolkata. So I'll start my questions with Dr. Sengupta. Essentially, so Dr. Sengupta, following your career, you did your MD in internal medicine and are currently specializing in clinical practice in neurology. So is this a relatively natural progression, or do you have something special to share with the JB scholars from your experience after MBBS that you think they would benefit from learning if they choose to pursue similar clinical practicing avenues? And also adding to that, among the options, let's say you had after MD, why did you choose neurology?
Good evening. Well, I would just first like to thank Debarghya and everyone of JBSPDF who has organized this meeting. Coming to what is conventional, really, because neurology is one of the what is conventionally called a super specialty and what we prefer to call as a subspecialty of internal medicine, really. The neurology was not really something which I had wanted to do from childhood or something like that. I mean, when I knew I would be going into internal medicine when I was, at least from my internship days, I was fascinated by medicine. Particularly, I loved attending the emergencies. Of my colleagues and all that. But when I went into what I would be specializing in, I think my answer that time, my stock answer was always anything but neurology. At that time, I used to find neurology a very dry subject. And we all had this conventional idea that it's a very boring thing and it's a hopeless subject. Nobody gets cured. It's a depressing thing. So that's usually that is the prevalent notion about neurology everywhere, really. We all had it. It was only during my peripheral postings during my, let's say, my second year, final year of medicine that I actually started discovering neurology as a subject. For, what should I put it? Let's call it for its mysterious nature. Because neurology, unlike some of the other branches of medicine, say for the interventional subjects, is not something a very definite subject, as you would call it. The human body itself is the most complicated machine that you deal with, and perhaps the neurologists deal with, and the neurologists and the psychiatrists that deal with the more complex part of it, about which we are on every day. We are having new avenues coming up. Anything that you know today, tomorrow that becomes redundant, and it's really the non-definite nature of the subject would always appeal to me. That it's so much open to interpretation, and more than anything, that we have this idea that neurologists, you go to a neurologist and they will write you, do a CT, do an MRI, do a couple of electrophysiology studies and all that. Okay. But when we come to know about the subject, we find that at its core, neurology is not about investigations. It's a very basic subject. Each and every investigation in our field is open to interpretation. If you are any neurologist, you can just manipulate the interpretation to fit your diagnosis. So okay. It's basically at its core, it's a clinical subject, and you have to stick to the basics of it. And that's what we have always found out, that the more you listen to the patient, the more you attend to the smaller things which you tend to miss out. That is what will ultimately help you to it. And it just makes you appreciate the smaller things in life a bit more. Because look, we will, as compared to say a cardiologist, we do not give such a definite treatment to anybody. But even the smaller things that a neurologist will give, you'd understand the importance of it to your patient and how much they appreciate it. So that was what I found very fascinating about neurology. And
got it.
That's really
so is it I guess something to what we lay people sometimes say, oh, when you walk into the doctor's office, half of your disease is cured by the ambience or the way the doctor talks to you. Is that part of your practice?
The dictum of a neurology resident is that your diagnosis starts when the patient opens the door of your clinic.
Okay.
That is the time when you have to start observing the patient. By the time he sits down in front of you will have a list of differentials in front of you. So
sorry, you broke off a little. Could you repeat the last part once?
It's like by the time the patient comes and sits down before you, you are going to have a list of differentials before you, because you have observed, you have noted the smaller things, and you know what you expect.
Got it. All right, so these are real life Sherlock Holmes. Thank you, Dr. Sengupta. So let's ask Professor Mukhopadhyay. So after doing your MD at BHU, you did a PhD, and then gradually moved towards primarily what I understand as non-clinical research. So was pursuing research always your aim since you did your MBBS or MD or even earlier, or did it sort of come up spontaneously as you went about it? Also, how easy or difficult was the journey, given that, to my understanding or to my knowledge, this is a relatively non-traditional path for a medical doctor with, and if we can hear your answer with a view of what you feel the current scholars would benefit from knowing who are also aspiring similar paths.
Thank you, Debarghya. Thank you, everyone, for being here. I have been interested in doing research since my since my college years, and that's why I'm a JBNSTS scholar. I think because I was so interested in doing research. But there is not a MD PhD program in India, and being going into medical school is something that is kind of written in our DNA, right? We go to engineering or medical schools, so that's like changing nowadays. But so I traditionally went into that pathway. I wrote to people in the field, like there was an article in Telegraph by Dr. Obaid Siddiqui, and he's like a very well-known, he died, but he's a very well-known scientist from TIFR. And so he worked on olfaction in the fly. And so there was an article on molecular biology in the 1990s. I'm very old, okay, not like you guys, you are young. So, so there was an article on that. And so that really was very interesting to me. And so I wrote a letter to him that Dr. Siddiqui, should I do medical college or should I go to traditional chemistry? Because I was very interested in chemistry. He wrote to me like, like he probably got like hundreds of these letters. And he just wrote to me that you do whatever you want. I think if you want to do a medicine, you will get an avenue later. So I went to medical college, and all of you are from medical college, my other panelists. So I was very disappointed, frankly, and I want to be very frank about it. Being a researcher, and many of my friends who were very much interested in science really suffered from that. And I saw it from the very beginning that the way traditional medicine is taught in medical college was not what some of we were asking for. So I did an MD after that. I was lucky because in the BHU setting, I could do research. It's not very easy to actually do medical research in an MD setting. I know AIIMS is a very good place, but I'm saying in a smaller places, it's very difficult to do that. I was very lucky. I got a mentor who had funds from ICMR and DBT, so I could work on my own in a lab. And BHU had some, a forum for doing research, and they are like, there was research in the environment, so I could do something. I didn't know what to do after that, frankly. Maybe teaching in medical schools, I didn't want to do that. I met a friend. These are true stories. I met a friend actually, I used to go to, I also did like interviews for PhD, and I felt that people were very like, like they were not supportive. That why is a doctor sitting in front of my table talking to me about entering a PhD? What I found was a lot of, disappointment that this is not necessary from you. You should do something else. In US, it's a complete different idea, but I'm talking of India. And so I used to go to these things. I used to go to summer research programs. I went to one in CDFD in Hyderabad, where I met a friend who was from IIT Mumbai, and he was a chemist. And he told me just write a something called GRE, and I didn't know what GRE was. So I wrote a GRE, and I picked up the colleges based on ABC. So A was Alaska, B was Brandeis, and C was Cold Spring Harbor. I started applying. I immediately saw that it was very costly to apply and time consuming. So I stopped till C. And at C, I saw that Cold Spring Harbor had like spoken English. I mean, who speaks in English, right? So I immediately stopped going towards Cold Spring Harbor. But I really wanted to go to Cold Spring Harbor because they had a real, like RNAi was developing at that time. I was reading in Nature that they had these new developments coming in RNAi. This is 1998. They're like discoveries by them at that point. So I really wanted to go there, but I was like, okay. So Brandeis sent me a very colorful, notebook of what they do in their university, and I was like hooked into it. I applied into 3 places, 2 places having my relatives, and 1 place which was Brandeis, and Brandeis got me in, and I was lucky. I went to Brandeis. There was no resistance from my teachers or my mentors, anyone. But my friends, many of them from India, were again very much like, why are you doing this? And so I again went through that. And but then, I wanted to do research because without that, without a PhD, I had no standing, frankly. I mean, I could not I even think of a problem in a way. I did papers in my BHU years, but I could not do that. So I did a PhD, and then after that I went into doing postdoc, and so it was traditional. But I would say that not all of my friends and who are very much interested in medical research have gone through the pains that I have gone through, and they're smarter than me. So I have a friend in Baylor, Ongshumoy Roy, who is also from medical college, who is 1 year junior than me. And these are the guys who are really inspiring to me. So he is junior to me. After doing an MBBS, he went into doing a direct PhD. Without doing an MD, he went into doing a direct PhD into Baylor. And he was also an inspiration for me because I went into doing an MD because again I'm a traditionalist and he's more of a a maverick. So he went into doing that, and he is now again an assistant professor or associate professor or whatever in Baylor, and he has his own lab. He is a pathologist. He does patients, like he goes and treat, like he looks into patient data. And so he has like timing, like he has like 15% time for patients, but the rest of his time he's actually managing his lab in doing like, so he studies RNA pathways in multiple tumor settings. So he has been doing that and he's fantastic. And so this is one other friend who has been doing this and who is a medical doctor in the same line. I have had, being in UT Southwestern, I have medical students who have been in, for example, in MGH as an MD or as a postdoc after their MBBS. And they have done that whole thing in as a postdoc in, and then they wanted to come back to UT Southwestern as a grad student. And they have done that and they are happy. They are doing a PhD here and they are, Jill Biden got a PhD in her 50s. Okay. So, I mean, it doesn't matter. You do what you want to do. And so they did that. And so he's very happy. He's working in one of the premier labs in UT Southwestern who does genomic sequencing in multiple diseases. So this is another example of a person who is a medical person who went into doing research. And so that's my story. Yeah.
Okay, thank you. I mean, I'm sure there are more to it, and some of the later questions might unravel some more. But in line with some what you touched upon, actually, one of our members who is not able to join today, he has a question that how feasible is it to conduct research as a scientist and catering to patients as a clinician simultaneously in India and USA or UK? Like you touched upon it a bit. Do you want to deliberate more on that? And maybe Dr. Modak or Dr. Sengupta can also say a bit.
Yeah. So I think you guys like Tamod and Ananya, you know better than me on this because I'm not a clinician. I already went out of that. But in US, it's very prototypical. So there are like I'm saying, they have like devoted time. Like I have a nephrologist who is just an MD friend. And so he has his own lab on kidney research, doing basic research on the kidney. And then he actually treats patients as well. I have friends who are MD PhDs, and they are like treating like lung cancer patients, and they are treating liver cancer patients, but they have their own labs working on mouse models of lung cancer and mouse models of liver cancer. And then I have friends, I have mentors who are actually MD PhDs, one from Harvard MGH, and they treat patients with germinal cancers, but then they actually model that in the fish. So it makes all sense to do that together. These are like really creative, really good people. I mean, I don't know how they balance both, but they do it. In India, I don't know much. I frankly haven't seen, like when I did my MD in BHU, I was in a BHU biochemistry department and we were just doing basic research. So I really don't know how you can do clinical research and balance that with your scientific questions in India. So you guys should rather tell that.
Sure. So Tamonud, Dr. Modak, do you want to step in and say?
Let me get the question again.
Yes, so specifically it was that how feasible is it to conduct research as a scientist and catering to patients as a clinician simultaneously in India? And if you also have knowledge about how to do that abroad, how if you're some of your friends are doing it abroad, how easy is it to do in both places?
In India, I mean, most of the people who are into some of these clinical fields, be it neurology, medicine, cardiology, at least in some of the institutes of national importance, they are simultaneously doing clinical research as well as some sort. It depends from the person to person, but some sort of basic science research. The problem of research in India is one of funding. There is a steep competition for funds. ICMR is really not funded as much as some of the other organs of CSIR. So most people do unfunded research, whatever they're doing, based on the resources that they have. And there is really a little amount of funded research that goes on. Of course, the amount of funding differs from institution to institution. There are 4 institutes of national importance in India. They are PGI Chandigarh, AIIMS New Delhi, NIMHANS Bangalore, and JIPMER Pondicherry. So they really get hold of the lion's share of the funds. And I do think that ICMR funds certain other institutions also. Besides these, ICMR has its own set of labs across the country. So it is possible to do research if you tie up with these labs, and how much you can tie up with these labs obviously depends on the areas the lab is interested in and the kind of connections that you build. It's possible. It's not very common as a career avenue.
And how about the balance between treating patients and doing research?
Well, that depends upon institution to institution, really. And these institutions of national importance, they have a developed culture of dedicating time to research, dedicating time to academics, and dedicating time to clinical work. These might not be present in some of the institutions that are governed by the state governments. For example, I can speak well of AIIMS. So in AIIMS, we have, and Dr. Ananya will probably criticize us for that, is that we don't take unlimited amounts of patients. Each department has a specific quota of patients. And so a doctor, be it a faculty or a senior resident, will have a specified number of beds he has to look after. So as a result of that, you do get time to pursue your research. Other institutions, especially where there is a lot of political pressure, that might not be true, especially if I have to talk about medical college, where the diktat is that you must attend to everyone who comes to you. People really don't get time to do that. I'm sure there are senior faculty who are able to take out time. One thing you must keep in mind in India is that you really need to be a very senior person to actually direct institutional resources to a particular field. For example, right now I am of the level of an assistant professor, so I don't get I'll have to step into someone's shoes, do his work, follow his interests, and maybe when I'm senior enough, I'll get some of the institutional resources to direct my own lines of research.
Got it. So I guess the short message is that it's definitely, it seems like it's easier to pursue research and follow, also attend to clinicians. Of course, there's always this balance, more so abroad India. And in India, the best places to do are these places of national importance, like AIIMS and PGI and those that you mentioned. And okay, so that's I guess that's good to learn. And following up with that, Dr. Modak, why would you tell us about your journey after MBBS, like why you got interested in psychiatry and addiction, and your current clinical research on the same, and also what's your view about pursuing? I think you already discussed about this, that or if you want to elaborate more about pursuing clinical or non-clinical research in India, if you have something more to say, but primarily, how you went about your journey.
When I joined medical school, I really did not want to become a psychiatrist. I didn't know anything about psychiatry. So I wanted to become a neurologist or endocrinologist or something like that. I think every student who joins medical school either wants to become a internal medicine specialist or a surgeon, for that matter. I share some of Professor Mukhopadhyay's disappointment with medical college. My interest in psychiatry was spurred by undesirable interactions with my colleagues and seniors. So I wanted to find out a reason why I was the odd one out. Let's put it that way. Of course, I wanted to go abroad, so I prepared for my US MLEs, and it is there where I had my first exposure to psychiatry, and I really thought that it was a interesting field to study. Additionally, I am not a very good student. I'm pretty poor in exams as it is held in India. So I really didn't want to study for a long. I wanted to study only for 3 years, and that's it.
You'll be very sad to hear that.
Yeah. I think I'm the expert in the room when it comes to commenting on intelligence. So I might have a more intelligence, but that doesn't mean I have other qualities that is necessary in a good student. So psychiatry was what we call an end branch. You do your MD and that's it. There is nothing else to do. You go into a clinical practice or whatever avenue you find ahead of you. The third reason was, while I was a JBNSTS scholar, I won this scholarship which is known as KVPY. It is awarded by the Indian Institute of Science and the Department of Science and Technology. This scholarship entitled me to visit various labs across the country. So I went to learn genetic engineering at IIT Mumbai. Then I had the opportunity to visit the Tata Institute of Fundamental Research. So we used to get these summer internships across the country. And really, they were a very powerful organization. So, one phone call and you would get a 15-day, 1-month internship, how much you want. So I faced some of the things that Professor Mukhopadhyay was talking about. For example, when I applied to IIT Bombay, and the professor in charge of the lab, he's a very big guy in biological research in India, NC Punekar. So he said that, you could do the same thing in a hospital. Why do you want to come to me? Why are you interested in biologicals? So over the course of time, I realized that as a result of decreased funding in India, the kind of research that we do is a couple of years behind what is being done in the Western countries. So you don't do any breakthrough research. The machines that you get, the Western universities and Western hospitals have already received them 10 years prior to you receiving it. So then applying for additional funding takes a lot of time, and you sit in your lab and we just wait for the funding to come so that you can pursue your research. So that made me a little less attracted to the other branches of medicine. Psychiatry had the advantage that we don't require a lot of resources. It's mostly a couple of pens, paper, that's it. So, and there is really a lot of opportunity to contribute to new things in the field of psychiatry. I had a couple of seniors who attested to that fact. And then finally, I got through to AIIMS. It's a prestigious institution to get into. So that's how my journey in psychiatry. Of course, when I came into AIIMS, I realized that, there is a lot more to do in this country than what we learn in some of the state medical colleges. I really, it's my fervent desire that, students in those institutions now, get the kind of exposure to the kind of, atmosphere that is there in some of these institutes. Regarding the work that I do, I'm essentially I have done my MD, and when I'm doing my MD, I'm a junior resident. As a junior resident, I attend to patients under someone's supervision, and the only amount of research that you can do is what you do in your thesis. When I'm not a PhD, I'm a DM in addiction psychiatry. So a DM, when you are doing your DM, you are a senior resident. And there you get the opportunity to participate in some of the research that is being conducted by the faculty. And you also do a thesis where you do additional work. So right now, at the age or at the stage of career that I'm in India, you are basically exploring different avenues of research, and you are deciding which one is the best for you. So in my MD, I have done a little bit of public health research, and in my DM, I've done a little bit of neurobiological research. Besides this, I've participated in some biochemical research that has been conducted. Right now, I am a senior research officer, but it's more of an administrative job. We are trying to expand facilities across India, and so it's not a clinical job or a co-research oriented job. You do, of course, gather some data, you test that data, find out your results, and use that data for some translational benefits. I think that's all I have to contribute.
So following on that, there was actually another question by Shupratim Sarkar. Since you said that you have a DM, not a PhD, so he asked that, what's your view on conducting research with a PhD versus without a PhD, but with a super specialization such as a DM or MCH, both in India and abroad? So for abroad, I guess Professor Mukhopadhyay can step in, but if you can say about India first.
The way we view research is there are two kinds of research. One is the clinical research, where we test out whether something is working or not. For example, the vaccines right now. So whether a vaccine is working right now, or whether a particular drug works, and things of the sort. Those are clinical. That's clinical research. For that, you need a clinical degree. Most departments, most areas of research, and when your research does not involve a patient per se, that becomes non-clinical research. So as far as India is concerned, if you want to do a clinical research, you need to do at the very least, you need to do an MD. And if your subject has a avenue for super specialization, for example, internal medicine has an avenue to either go into DM in neurology, cardiology, infectious diseases, something or the other. So if you want to do a neurology research in neurology, you would need a DM. If you want to do non-clinical research, it is there where we have seen most of the PhDs coming out of our institute. For example, in AIIMS, New Delhi, PhDs are awarded mostly by departments such as microbiology, biochemistry, anatomy, pharmacology, per se. A few people do PhDs in clinical subjects, but that's far between.
Got it. So it's primarily not something is more valuable than the other. It's primarily what area of research that you would, whether it's a clinical or a non-clinical research, will primarily sort of drive what kind of degree.
Yeah. So in research, almost this is like Faraday said, what is the use of electricity? It's what's the use of a newborn child? Research is something like that. And most people, when you are in medical school, when you are young and you are new to the field, you would feel interested a lot by basic sciences, and feel that they are challenging enough. But in India, if you really want to do breakthrough research, that happens only in the field of public health. And public health is probably one of the most boring subjects that you can study in medical school. But so, for example, if you look at the kind of work that I have done, my work in MD, which was a much more simpler work in public health in addiction, it got an international award. But the work in DM, which was neurobiological in nature, when I studied the literature, I found that people in Germany or the US and Canada, they had done it 10 years prior, and I had nothing new to show. So a naive person might think that public health research is not very rewarding, but if you come to the reality, that's the best kind of research that you can do in India.
Got it. Thank you. So, Professor Mukhopadhyay, do you want to step in and answer this question? That Is there a difference between having a PhD versus not having a PhD? Like, for example, you cannot get a job in some places if you don't have a PhD. So how does medical research tie to having a PhD versus not having a PhD, but having like a DM or MCH to pursue research in US?
I think I have seen multiple students who apply to our school after doing MBBS and as for a PhD. And to those students who are applying, I would like to say, like what Talmud was saying, that he went for this KVPY program. I think we would really like to see that in your CV, that if you have some kind of a summer internship or summer research experience in a lab, in a traditional research lab, that would be very good in your CV to have, because we know, because it will come to us, and we know that in a medical college, you are really not being ingrained with how to do basic scientific research. I'm not talking about what Talmud was talking and clinical research, which is a completely different avenue. So if you're interested in basic science research, you really need to have that in your CV. You really need to get a summer, 2 summers training before you're even thinking of applying to PhD, because there's a lot of resistance in just getting you as a research scholar, because you have no idea what research is um, in that aspect. I have seen students who have done after MBBS, they have gone for postdocs. And that's my whole point, that I know these students, when I was in medical college, I knew they were very unhappy about being not being able to do basic scientific research as a medical doctor. And I felt it. I lost a friend that way, in a very sad way, actually. And so I'm very I really want to tell you this, that clinical research is fantastic, that's different. But if you want to do basic research, there is another way to do it. In this case, this person, he came to MGH, and in MGH he did a postdoc after MBBS. You are actually a graduate, so you can do a postdoc. And he did a postdoc, and then he again came back to UT Southwestern for doing a PhD. Now, whether you do a PhD or not, oh, okay, I have a very good example also here. So I have a friend from medical college, Supriyo De, and his father was a surgeon. So when we were friends in college, he really wanted to be a surgeon. So, he used to commute from home, and he used to be like, he was like his father's child. And being like from a family like that, you can imagine that he would like to do that. So this guy, he did an MS. I may be wrong, but he did an MS, but he used to dabble with computers. Okay, and there are people like that also in Cold Spring Harbor who are like MD and who are actually computer scientists now. I don't know how they do it. So Supriyo used to do that. And so he was good in computers. I don't know what exactly he did. He is now actually in charge of bioinformatics in NIH. So after doing his MD, MS, you can ask him, you can write to him, Supriyo De, I think his name is. And so after doing his MD, MS, I think, he came to a lab in the US to do bioinformatic research, because he was at that time, there was an explosion of human genomic data and everything. He self-taught himself. I mean, everybody is self-taught, right? So he self-taught himself, and then he went into doing bioinformatic research and computer, I don't understand anything about this, but he went into doing research into understanding data sets, data mining, and all these terms that we hear nowadays, machine learning and all these things. So he can do these things, and he is in charge. He directs the bioinformatics lab in NIH. That's a huge thing. Hats off to Supriyo. So that's what, so this is again a medical person who went into research without doing a PhD. So you will always find a lot of resistance, because you are not a you are not a traditional research scholar. And so you will have that resistance, one. So you have to find people who are going to support you. And once you find support, then you can really do what you want to do. And the other thing is that you can also increase the credence of your CV by doing these things, like Tamonud was saying that he went into and he did that KVPI program. It really increases the scope of your CV. And that way you have an experience what real basic research means, because it's very different. It's completely unrewarding. You will not get nothing. You will get nothing for 99% of your days. On one day, you will get one thing that will change your life forever, and maybe this planet. So that's that's the thing about basic research, and you will never know it, nothing works. Okay, so it's not like you. It's very satisfying. It's a complete different way of looking into things. It just builds on curiosity. There is nothing, and method. You have to know what you are doing. So you need that kind of a background when you are coming into doing a PhD in basic research. So that's my point. Yep.
So yeah, thank you. So on building on that, we have actually been requested. So a part of our forum has this vision that similar in some ways to KVPY. Of course, we don't have the resources, like monetary resources right now. But if we can establish links, and this is also based on, let's say, personal experience of what I also experienced during my undergrad, and we had a lot of difficulty getting the internships in Indian or abroad universities. So, what would your recommendation would be for those looking for internships? And would you be in a position to personally accept someone to work with you, not taking into account the let's say they have the monetary resources to fund themselves for 2 months or something like that?
Yeah. So, okay. So that's it. So for regarding us, so we have undergrad, and so we have undergrad programs where students in the US who are doing undergrad or high school, they come through a program into UT Southwestern to do summer research. Now, I think people like in MGH, like I was telling you an example, they have more liberty in accepting students in a way that they can do these internships. So you may actually, even if I am unable to, because our university doesn't allow you to be taken unless we pay you. There's like, we have a rule like this.
Yeah, right.
And so for that reason, we cannot do that. But there may be other people who can help you with that. It doesn't help. It doesn't like if you want to do something. I went to, for example, I went to the IICB Calcutta, wherever I could in my medical college. I went there in IICB Calcutta. I went to the other institute, which is like doing the Cholera Institute. So I went there, I saw how I was doing research. It was like heaven to me. I mean, oh my God, they're doing a Southern blot. That's like amazing. So I went to IISc India when I was there. I went to CDFD. I went to all the places I could to find out people like me, where, I could find people doing research. So do whatever you can, like whatever
So
you.
I guess one of the things is to establish connections. Like, I am, let's say, a random undergrad student and trying to write to people who I don't know. I don't, like, Professor Mukhopadhyay does not know me. I know Professor Mukhopadhyay from his profile, but he doesn't know me, and he's receiving these, let's say, applications from 100 Debarghya Sarkars, right? Is it, even though it may not be possible for you because of, the logistics difficulty that you mentioned, if you have some connections in India, if students reach out to you, similar to what Dr. Modak was saying, it's like a phone call and, you get like a 15-day, 1 month, 2 month internship, would you be able to help in some similar way?
Okay, so I have had a lot of heartbreaks. Debarghya, you are nobody. Like, if you write an email to me, I'm going to read that email because I am, you are very bright, and in a way that this is how science works, right? We are always looking for students who are bringing in ideas, and the idea is the beginning of the project. So I think, so I have been through the question you are putting, like writing an email and getting no response. So I did that to multiple people, right? So I've written to people, like there's a science paper that came out from JNCSR. And I wrote to this guy that, I was like dying to do something as a research after my MD. I had no idea there was a GRE program. So I wrote to this guy, can you please accept me? And then no response. So you will not get a lot of responses. Many of the students will not get a response. But you need one person who is going to mentor you, one person who is going to take you forward in a way. So when you're writing to someone, try to address some things, like try to address how you can contribute to the projects in their labs. That's very important. Have you read the papers? Are you just writing in the cloud, or are you really interested? People are very intelligent. They will get through the nuances of your email and understand exactly whether you are interested, or you are, as a basic research scientist, you are coming here just for an USMLE. I'm not interested in just taking in somebody who is going to be just going for an MD program here. So you have to be very careful and interested in a way that you're framing your email and writing it. And that way they will know that you are solidly interested. And this is how people are coming from medicine into doing research. There's no reason why you should not be doing that. The other thing is that when you're doing your CV, it really helps if you have all these previous experiences. And I think the email has to be very much, this is a basic mistake people do. It has to be really written in a way that you're addressing this person. Like somebody will write to me, "Dear Madam." It doesn't help, right? Somebody writes to my wife, "Dear Sir." So it means that this person even doesn't know what they're writing about. So these are basic mistakes. But if you are really interested about doing research, you will find a way. I mean, all the students here, if there is anyone who really wants to do research, try to do anything you can, and you will find a way out, okay? Don't be disappointed. There will be someone who is going to support you, someone who is going to take you on, and then you are going to support them later, right? This is how things work. Yeah.
Got it. So if we
if I may add to something Professor Mukhopadhyay was saying, so yeah. So one of the things Sir pointed out, he said he visited IICB and various other institutes. So that's kind of important. I think for the new medical students who are watching this discussion, it's important to expose yourself, and that is how you climb the ladder. For example, to get the KVPI scholarship, I needed to present a kind of a research paper, but medical college doesn't do that kind of research that gets awarded the KVPI scholarship. So I got hold of Papiadi and I told her, "Do you know someone in IICB?" And then she knew someone in IICB, and then I got hold of that person and said, "Sir, please let me do something on, give me 6 rats. I want to do something on 6 rats and publish a paper." And then I had to get hold of a friend whose father was a senior scientist in IICB and use his microscope and things like that. People generally open up, if you're persistent enough. Persistence is a proxy marker for how interested you are. And yes, there will be disappointments when we are applying abroad for MDs or observerships and things like that. If you write 100 emails, hardly 2 will reply. So that's the name of the game. You need to do that.
Thank you. And if we move to a little away from research and more traditional internships, let's say, I'm sure medical students in general do internships, if I'm not wrong. But how easy, like if someone reaches out to you and say, "Dr. Sengupta, I would like to do an internship in your place," or how would you guide that person?
Look, in my place, we are not so much into research related as such,
Let's say clinical
research, a bit of maybe, because
or no, let's say as a medical practitioner,
okay.
Not necessarily research. I don't think everyone would necessarily want to do research in general, but may want to do an internship from a good place in India. So I don't know how really the competition or how really the passaging works, and how important is it for networking.
In India, the thing is, you can officially do an externship if you want, anywhere if you want it. That's an official thing. Unofficially, you can work with people, because in our department, we had a few people working with us who wanted to get a feel of the subject, and they came after their DNBs. We had 1 or 2 people coming and working with us because we have a lot of patient load, we have a lot of variety. And yes, people do come and we have worked with us. But it would be entirely, it's more or less on an unofficial basis, you could say. And how much time we can devote, it's a bit of a problem because of the huge load we cater every day, which is one of the major problem in India with government hospitals.
Got it. So as we are towards the end, so Professor Mukhopadhyay, we have been speaking about research. Do you want to present to us like some high level view of the research that you currently are pursuing, and how that's something about your
Yes.
research?
Sure. Thank you. I will probably have 5 slides, and I will try to share my screen and see. Can you guys see me?
Yes.
The screen?
Yes.
Yes. Okay. So we have been trying to understand the role of primary cilia in development and disease. And as you all know, I'm a doctor, so I really look into mice as my patients. So I try to understand the diseases they have, just like a doctor is trying to treat patients. So that level of thinking is something I am indebted to for my medical school, because it put me into a position where I'm always trying to understand what's causing this. And for that, we try to understand how the primary cilia is causing different kinds of diseases. Now, this is a picture of an embryo in mice, and you are seeing a cross section through the mid level of the embryo, and all those small dots are actually something called primary cilia. And you can see that it's almost present in almost every cell in an embryo at this stage. Now, as you see, these are like almost small, teeny weeny dots, and believe me or not, if you disrupt function of proteins going to this place, or if you disrupt these organelles, then you have profound effects in the embryo and in the adult. And as a background, I think these are highly conserved microtubule based organelles, and they were actually seen by Leeuwenhoek when he started looking through his microscopes in the pond water. So those pond water protists, they are like unicellular organisms, and they swim through these long antenna-like cilia or flagella, and these are motile cilia. For example, also many of the medical students will know that in the airway we have these propulsing multicilia, which are actually propulsing the mucus in your airway. And so these are also variants of the cilia. But then other than that, there's also a kind of cilia which is present in almost every cell in our body, except a very few like exceptions. And they are called primary cilia. For example, in the neuron, you have a primary cilia shown here, which is present in the cell body of the neuron. And for example, this is a neural tube in the embryo, and you can see that these are all like projecting into the CSF, or the spinal fluid. And so these structures are actually so small that even though Leeuwenhoek saw it like 300 years back, they were completely forgotten. Like for 300 next years, nobody really paid any attention to them. They were thought to be vestigial, and it was like an appendix in the textbooks. Then when I was doing my PhD like 20 years back, suddenly, because of the power of human genetics and genomics, people started discovering mutations in multiple genes that were actually being shown to be affecting the protist chlamydomonas, like the picture I showed here. So diseases like genes in humans were shown to be causing defects in a chlamydomonas and in the flagella, and that's how the link started. And then some people saw that those genes were also present in kidney cilia, and then the kidney cilia then became very like an avenue for research. And then somebody in Sloan Catherine did a genetic screen, and then she found that defects in mice development were being caused by a gene that was present in the chlamydomonas, but which was mutated in the mice. So these kinds of connections, it is in early 2000, told us that this is a really fundamentally important compartment which has been forgotten, and that we need to understand it because it's dictating what the cell or the tissue should be doing in a very important way. And so you can think of it like as a small antenna in your house, and that is actually telling you what you are going to get today in your TV. Like today is Super Bowl here, so it's a big thing. So so what I'm saying is that this small thing, even its size of a few mitochondria, and that's the point of this slide. It's only 5 microns. It's size of a 1 or 2 mitochondria, and that small organelle is having all these proteins go there, localize there, and then function in signaling, and then causing differences in a cellular level, and then in a tissue level, and then dictating all these different phenotypes. So these phenotypes are something, or these clinical symptoms. Actually, phenotypes is for mice, but these clinical symptoms actually started being discovered in the early 2000s, and people found that these genes were being affected in neural tube defects, in cystic kidneys, in liver cysts, in also retinal diseases and retinal degeneration, in polydactyly is when you have multiple fingers, and also in obesity. And one of the reasons I actually went into working into Cilia was actually, again, serendipity, because I used to work in Brandeis in C. elegans, which is a worm, a lowly worm. And then in C. elegans, I was doing genetics. I was trying to look into the neurons in the worm head that senses the environment. And so in doing so, I got into some papers which were being published at that time by Gary Rufkin, who is in MGH. And Gary Rufkin showed at that time that, defects in these cilia can actually result in the worms getting fat. So they started having fat in the intestine. So this is very common to you guys, like, this is neuroendocrine signaling. So neurons in the brain is telling your intestines to do something. And I mean, this is a basis of a lot of psychiatric illnesses nowadays. You guys know better than me, and also neurological disorders. But what I'm trying to say is that this neuroendocrine signaling was being modeled by Gary Rufkin in a worm, and the link was between a cilia in the head of a worm neuron sensing the environment with an intestinal fat storage. And this was also seen in a lot of patients of these ciliopathies or ciliary diseases who are ungainly obese, and they are really obese. And so there is like signaling happening in the brain that is causing it. And this is the reason I actually wanted to do my postdoc in a lab where I really wanted to understand how this protein TUBI was functioning, and how TUBI means fat actually, and how this TUBI gene, which is a monogenic syndrome, was causing obesity in the mice. And we don't know the answer yet. It's a very complex answer, but that led me into actually studying proteins that are really important in ciliary signaling. And one thing led to the other. The studies on TUBI led me to another protein called TUBI-like protein 3. And by looking into that, we got a handle of how we could really manipulate things moving into cilia, things moving out of cilia, and then looking into the signaling pathways. And this is very rewarding. So these are pictures I'm showing you from my last 7 years of research in the lab. And I didn't do it. It's all done by our lab members who are very talented. And what you are seeing here are these different kinds of diseases that we are modeling in the mice, and trying to understand how we can actually develop therapeutics so that later we can treat these patients. So these are very rare diseases. But then, in some cases, these patients, they come to our meetings because they want to get treated. We have seen their children, they come to our meetings and they really want something so that they can be helped. And although this is not as common as diabetes or general obesity, but believe it or not, they can really become important in some way in these general diseases as well. And so if you just look into these pictures, and you will know this is a normal kidney, and just doing a defect in a single protein which traffics something to the cilia causes these huge big kidneys with cysts. And again, if you look into this embryo on the left, which is a normal embryo, and so here, this is an abnormal embryo which has a defect in cilia signaling. What you are seeing here is the face is completely open. The brain is not formed. This is called exencephaly. And then you see there is spina bifida, which is like neural tube defect. And then you see there is no forelimb. And so these are all the kinds of diseases that are being caused by cilia signaling. And then if you now see the pictures here on the left, this is a normal embryo with the skeletal staining. And then if you see an abnormal embryo, again, a defect from cilia signaling, you see there is no cranium. There is no bone in the cranium. And then you are seeing polydactyly, and then you are also seeing a lot of skeletal defects. And actually, defects in some of these proteins cause skeletal ciliopathies, which kind of are similar to the phenotypes we are seeing. And then this is a cerebellum, and unfortunately, I don't have a picture of the forebrain, and I think I should have kept that because of my fellow panelist. I mean, she would love it. So in that case, we have defects in the forebrain in neurology, and so we have modeled periventricular nodular heterotopia, and we have also modeled a variant of hydrocephalus in our diseases. And I just took it off my slide because it was too much. But this is a cerebellum. And in this cerebellum, what you see is actually a tumor. And again, this tumor is being caused by a defect of a protein that is trafficking to the cilium. And so the point I want to make is that by understanding a chlamydomonas or a protist or a fly or a worm, and then a mice, and then doing genetics in humans, we can really model diseases in humans. And then going from there, we can develop ways by which we can treat these conditions. And I work in UT Southwestern, and I'm very lucky to really have very good students. I'm not happy with them all the time, but normally we are a happy bunch. So that's it. Yep.
Thank you, Professor Mukhopadhyay. So Professor Mukhopadhyay builds on this starting from ciliary signaling, and then how that builds to different diseases. And Dr. Sengupta, you look at patients and you try to figure out what their diseases are and try to cure them. So do you want to tell us about, let's say, a typical day at your work, or some special moments that you had, something exciting that may not be very, very common for everyone to know, something about your work?
Well, the journey through neurology for me has been interesting in a way, fascinating. Some days it's depressing, as I said, because you cannot really run away from the fact that there will be days when neurology is a very depressing subject. You will have days on end when you do not give any answer to the patient, when they will ask you when they will get well, and you don't have an answer to give. But there are days when you see improvements which you had never expected. Like, I would just like to share the experience that there was this lady in the ICU which we used to go and see her. She wasn't admitted under us really. She had gone into cardiac arrest at the time of a delivery, and it was really more of a vegetative state for that. And because she was in the ICU, but her primary physicians, they were all losing hope, and we were being called. And even from our department, it was we juniors, we were talking to the relatives every day, giving them mental support, and given the treatment it was going on and all. So after that, I had a posting somewhere else. So I was off for a few months. I had also taken leave or something like that. I was busy with my thesis. So I think it was around 4 or 5 months later, it would be, and a lady walks into my OPD and she just says, "Doctor, do you remember me?" So I was like, no, I couldn't recall it. We see so many thousands of patients every day. I was like, no, I usually recall my patients, but I just couldn't recall her. And she was like, and her husband said that, "You don't remember me?" And it is, I look at the husband that I recalled, it was the same lady whom we were seeing in the ICU, and everybody was losing hope every day. And okay, there were deficits, but the lady had come to us walking, and she was like, you gave new meaning to our lives, and now I'm taking care of my child as well. So yes, there will be days when you will be happy as well. And there will be, and sometimes like sticking to the basics gets you some unexpected diagnosis like that. There was this lady, this was during my medical college days, it was basically during my MD days. And I was on my peripheral posting in neurology. And there was this, and anybody, and even Tamonud would tell you, we keep getting patients of headache every day. Every neurologist, psychiatrist, we handle headache. And we just like, the patient comes in and we write and, oh, it's over like that. So there was this lady and she had come to us and she had been having this headache for a long, long time. And people were she was going from one doctor to another and all that. And the neurology resident, he was at medical college and he was just trying to teach me the basics of how to deal with a patient of headache. One of the things is that you should do a fundoscopy on anybody who comes in with a headache. Lots of times we cannot do it because we are short of time. But he was teaching me and he asked me, go ahead, look. And there what we found to our surprise that it was what we call an optic atrophy in an eye. That is, the nerve was drying up in it. So we went and further investigating the patient. We came up with the disease. It was a demyelinating disease, which we call an NMO. We couldn't save the vision that eye, obviously, it was lost, but we prevented the further attacks of the patient. The patient was thereafter, when I left medical college, she was leading a less of a normal life regarding the vision in the eye. So what I mean to emphasize is that sticking to the basics, listening to your patient, giving them a bit of your time, that is what has been most rewarding for us. The CTs, the MRIs, the electrophysiologists, they will come and go. They will form a part of your clinical career, yes. But overall, for us, you have to concentrate on the patient and you have to look into them, hear them out, think about them, go back, again, read about them. I mean, when I took up neurology, I was like, I want a cool life. I do not want to be like my cardiology colleagues running around at the middle of the night. At that time, I never imagined that at 3 a.m. at night, I would be getting up. I was on holiday at that time. I would be getting up because one of my juniors had called me. She couldn't understand what the patient was. And I had actually sat up. I was starting and reading up that disease. It was like a difference was asked between she had been presented with the patient that you have got a call. Is this a case of rabies or is this a case of a Guillain-Barré syndrome? Now it's something which I'd never heard before. So I was like, I don't know. I will read this up. So at 3 a.m. at night, my husband was saying, are you got mad or what? So no, please, I have to do this. So we read that up, we read it together. And yes, it was something new that I learned. And it's a clinical differentiation that we learned that day. So every day is a new step in our journey, I would like to say. And the people I've worked with, even when I was in Kolkata working after my MD, and now, and there are different setups. That was a private setup I was working in then. Now I'm working in a government setup. Perhaps the time you spend with the patient differs. In a private setup, your patient load is far less as compared to here where we are handling 200 patients in a 4-hour OPD. So, but the basics will always remain the same. And you have to learn to differentiate between where you have to give time and where you really should listen.
Got it. Thank you. So Dr. Modak, do you want to share some more about your current research? We have heard from Dr. Mukhopadhyay and Dr. Sengupta. Do you want to go ahead?
Well, I really didn't know that, I had to make a presentation. So I'll just...
No, not necessarily presentation.
I just speak.
In more depth, so, what do you do in psychiatry and drug addiction research?
Okay. So even when I was a MD student, most of my research was in the field of drug addiction. Probably the most breakthrough thing that I've done is that I compared the costs of treating patient in one particular treatment versus another. And you will, when I tell people this, especially people from some of the more core branches of medicine, they will say, okay, I'm sorry for the language, but yeah, it sounds very unsophisticated, benign, and any mundane and any other words you can use. But that, interestingly, was the first of its kind in the world. The results are very different in India compared to Western countries, and people abroad were genuinely interested and surprised with the findings. This is to highlight my point, that you might feel that public health research is not exciting enough, but it has its own perks. My neurobiological research was, I did a kind of a electroencephalogram. It's called a quantitative electroencephalogram, where a computer uses Fourier transformation of the data to find out various things that's happening in the brain. So I exposed patients who had problems with alcohol to pictures and images of drinking, advertisements, so on and so forth, and just try to find out what was happening in their brains as far as the QEEG is concerned. That had some interesting results. I mean, I did find out that drinking alcohol and viewing a picture of alcoholic beverages that we commonly find on our streets, on our billboards, in the newspapers, in the form of music CDs, and something which is called surrogate advertising. So they had similar responses as far as the brain is concerned, and that might be important as far as public health of alcohol treatment is concerned. But as I alluded to before, it's as far as the sophistication of the research is concerned, this is not as sophisticated or as my earlier works were, primarily because the kind of QEEG machine that we have here in AIIMS, I mean, it's a very expensive machine, but it's still 5 years after UCLA and Harvard and I forget the best institute in Germany, I forget its name. So they had it. So yeah, that's a definite drawback that you face in India. On a personal level, using my own funds, paying out of my own pocket, I have dabbed in using digital technologies to transform healthcare. They have not really led anywhere. Most of them have been failures. The best, I wouldn't say it's the best. I would say it's the most work I had done is I had vapes and e-cigarettes are quite popular nowadays. So I had modified a vape and e-cigarette, inserted some computer controls and some algorithms in its chips to use it to wean people off smoking, just as an add-on to the other treatments that we give for smoking. But there is another problem with research in India, and that's policy. So we applied for a provisional patent, and I think it was in August 2019. And then in October 2019, India became the first country in the world to completely ban vapes, e-cigarettes, so on and so forth. So that led to nowhere again. So this is another problem that you find in face while conducting research in India, is that the policies may be either too reactionary or too outdated. You face problems on multiple levels. So that's just about the thing that I've done. It's not a lot, definitely.
Sure, thank you. I would just like to add a bit that, about the resources that you were mentioning. I have also, done some research in the US, and one thing, like from Dr. Modak, we have heard a lot of complaints, and I totally understand, having, done my undergrad in India and many of my friends in India. But one thing to also clarify is that not everywhere in the US is the same. There is difference between, let's say, Harvard and any, other universities. So in my field, let's say I did my PhD in electrical engineering, and the clean room facilities at UCLA is different from the clean room facilities at USC, different from the clean room facilities at MIT. Okay, so it might seem it does seem from India that, we hear, oh, Harvard has done this or MIT has done this, and we think that US, we generalize it to US. That's not true. There is a lot of difference across US as well. So it's definitely, like, India has a huge population, and there are policy, issues and things like that. But the differences in resources they exist everywhere. People here fight a lot for money. The money distribution is also quite non-uniform. It depends on the institutions and the rank that you have, things like that. And there are also, like you were saying, having policies and things like that. So yeah, the policies on abortion and things like that, they also have influenced research on like stem cells and things like that. So they are everywhere in the world, I think. All right. So one thing I would like to ask Dr. Modak, like to add to what you already said. I think in one of your recent feedback, you mentioned that you would like to, you're open to sort of teaching or offering some short course on psychiatry and addiction, if I'm not wrong. And do you want to say a little, like sort of advertise a little bit to the current audience? And if someone is interested, please reach out to Dr. Modak, and if needed, JBSPDF will sort of organize some small thing for that. But yeah, please.
Yeah, my offer was from the viewpoint that people generally don't have a very good idea of mental health, and not only that, and since JBNSTS is the cream of the society, intelligence is also associated. It's unfortunate, but intelligence is also associated with mental ill-being. So my offer to any scholar, if he or she has faces any sort of a problem, either in dealing with people or feeling that they're not worth it, or they're off, or they're the odd one out, do reach out. I'll be glad to help, and I'll be glad to extend the best resources that we have to help you out. That's it.
And I think you mentioned, did you mention about offering some course, like you want to like sort of do some teaching to people who might be interested or something of that sort?
Yeah, sure. I mean, it's just a suggestion. So if your organization wants me to introduce people on how to stay healthy, or when to identify that you're facing problem and you might get help somewhere, I'll be glad to do that. Especially it's definitely true for psychiatry as a science, and it's even more true for addiction. I do get a lot of people often think it's a habit rather than it's a disease, and people often think they can quit on their own rather than taking some help. So if anyone feels any need for them, their family members, or anyone they know, I'd be glad to offer it.
Thank you. So I think with that, we are pretty much close to our time. And are there questions from the audience? You can unmute yourself and ask the question in person, or you can put in the chat box and we'll read it out for you.
So can I tell two things based on what we are hearing? So one thing,
yes,
that Talmud was saying, Tamonud, sorry, I'm butchering your name, Tamonud. So what he's saying is very important. I think he is very generous with his time and support, but I think we all go through these periods, being creative individuals. You will always face these things. So please take help when you need to. I have lost friends because of these kinds of events, that they were not happy with their academic setting, and it was very unfortunate. I have lost 2 friends this way. So I'm very much into mental health and the fact that that this is not a disease. It's like normal flu. You have to get treated. There should be no stigma around mental disease. That's one thing. The second thing I wanted to point out is that regarding regarding different institutes that Debarghya was saying in US, I think it's a very important point. You should really look into the labs where you are going to apply for your internship or your research, and you should look into publications. Is this guy productive? Is something going on in the lab? Is this something I would really like to do? And then do a Skype interview, so that you try to understand what's going on. Just don't jump into a US lab because you want to go there. That makes no sense. Yeah.
Thank you. So there are a few questions. How to get in the field of drug trials, etc. in India? And does doing MD pharmacology help in drug research? I guess Dr. Modak may be able to answer that.
Yeah, I'll be glad to. So, as far as drug trials are concerned, there are many kinds of drugs. Your drug might be already there in the market, and you might want to try it for some new disease, or you might be talking of a chemical that's not there, or you might want to talk about a variant of a chemical, like the hydrochloride salt might be there, and you might want a different kind of a salt. So as far as drug trials are concerned, India is the capital of the world. So that's a good thing. Depending on the branch that you are in, if the chemical is already there in the market and no one prevents you from trying the drug, all that you have to do is you have to get permission from a supervising ethics committee. So basically what you have to do is you have to write to them. Different institutes have different formats. You have to write to them, you have to apply for them. They usually hold meetings every month or every 2 months. And once you get permission, you have to, follow the steps of doing the drug trial. And depending on your results, you can publish them. If you're talking about a chemical that's not there in the market, then you have two pathways. There are a lot of pharmacology companies in India which conduct research on behalf of Western companies. For example, some of the drugs for COVID, if you looked at the research, they were actually conducted in India. The drug they might have been seeking permission for use in the US, but the research was conducted in India. So these kind of researches are generally very expensive due to some things that happened a couple of decades ago. ICMR has put a lot of restrictions on how you can do them, the kind of insurance that you need to get, and the kind of compensation that needs to be awarded. So these companies are your best bet as far as for chemicals that are not there in the market. And for variants of chemicals that are there in the market, well, the law has changed recently, and you need to do full research. Earlier, the law was that you could market the variant in the country and use post-marketing surveillance to publish your results. But now you have to conduct all the preclinical phase and the 3 clinical phases to market it in the country. But even then, the requirements are less than for an entirely new chemical. Some of the like these institutes of national importance and some of the eminent institutes, if you are a member of these institutes, you get to do these kind of research. For example, outside the institutes of national importance, KGMU, BHU, then there is KEM in Mumbai. So these are some of the famous institutions who do these research on behalf of pharmacological companies. Yes, an MD pharmacology degree will help in doing drug research. It really depends on the place you have done your MD pharmacology from and the kind of company that you are working with. Okay. I guess that's the answer to that question.
Briefly, does your work sometime also involve, participating in drug trials? Like, do you get to do drug trials on your patients? Dr. Ananya Sengupta?
Oh, sorry, I apologize for my net connection a bit. Net connections in Delhi been horrible for the past 2 weeks. No, in our settings, we have not had a lot of opportunity, mainly because ours is a very new department. But yes, in normal settings, where there is a well-established department, they are definitely conducted. My husband works in one of the peripheral colleges of West Bengal, and even then in dermatology, they're having drug trials conducted there. So it basically depends on the faculty. If he or she is interested, they can carry it out. The institutes generally these days are more encouraging towards drug trials. So yes, they are conducted more or less. In our hospital, other departments have conducted drug trials. It's because we are a new department with a shortage of members. That's why we haven't had too much of them.
Thank you. So Shoujo is asking, for MD in clinical fields, is US better than India, considering non-academic aspects like cost, legal issues, etc.?
Dr. Ananya, you want to take up this question?
Well, for the clinic going into MD into clinic, if you're talking about the cost, I really don't know how the US is going to be better. So if you're doing in the clinical field, if you'll be, I'm actually not so much acquainted with the US mode of US system. I have friends in the UK, but majority of them have first done their MD and then gone on there. I mean, from my contemporaries. Even I have worked in Kolkata, I have worked in Delhi, and I have found the clinical field to be better in Kolkata as compared to Delhi. Because
Right.
I don't know, somehow you concentrate more on the basics, and because Kolkata is more of a research poor settings, there are certain advantages of working in a research poor settings where you are working in a clinical field. Because then you know that I have such limited amount of resources and I can only use this much. And I can go till then, if I have to treat my patient, so I have to adapt myself accordingly. Somewhere I have found by working with the people back home in Kolkata and in Delhi as well, that perhaps sometimes it's contrary to popular belief, it's better to start with a resource poor setting and then go on to someone where you can order anything you please. AIIMS is ahead of us in this respect. In Safdarjung, we still have some restrictions, probably AIIMS is far ahead of us. So Tamonud would be in a better position to answer that.
I'm no fan of the neurology department here. I am no fan of the neurology department here, so.
Thank you.
But I do have a lot of respected seniors as well. Yeah.
So let me ask more specifically something I also wanted to ask. Essentially, the MD that people do in India, and essentially the structure of medical education in India and that in the US are slightly different to my understanding. And I learned that kind of recently. What we understand as MD in India and what is done as MD in the US are probably not the same. And there is also something called MD PhD in the US, which I don't know if it is there in India right now. So do you want to elaborate a little bit on this, Professor Mukhopadhyay? Because I'm sure some of our junior colleagues may not be entirely aware of these differences, and what is an MBBS, and what do people mean here by pre-med, and what is medical school? What are the differences?
So in the MD program here, you can do a fellowship. It's not a residency, but you can do a fellowship after your MD program in a lab, and then you can be immersed in lab research, and then you can be a scientist based on that. So I have a friend in nephrology who is an MD, Vishal Patel, and he treats he treats patients with polycystic kidney disease, but he's an MD, and then he did a fellowship in a lab, which is a science lab for like 5 years, and then he made his own lab. So that's like there's a scope of doing research after you finish your MD. The medical education wise, it's not very different. I think the courses are more modular, the way we were taught in medical college. I'm sure it has changed now as well in India. And they use a lot of digital platforms and other ways of training and teaching. I think these are being applied in India as well. So I think training wise, I think especially training clinical scientists, I think it's probably even better in India than in the US. I don't know, that's my bias. And for MD PhD program, I don't think there is a program like that in India. And I think that's a very important thing, which probably AIIMS can start. I think that would be a good avenue for a lot of students.
So AIIMS has a few MD PhD programs in some departments.
Okay, good. Yeah. So yes, so that would be a very important avenue for the students who really want to do research. Like I'm getting a question here, which is for Modak, Dr. Modak, and Southam is asking, like he really wants to get to a pathway of light, right? So we need an MD PhD program like that. And so we don't have that in MD PhD program is very different. You start in MD and then you go to a lab for 2 or 3 years, you do a research, you finish a PhD and you kicked out of the lab and then you finish your medicine degree. So that's the MD PhD program here.
Okay. So essentially, maybe I want to know, is the pre-med in the US similar to MBBS in India?
Yes, the pre-med in India is same in the US. I think, yes, I think it's pretty same. I think the teaching wise, it's just taught with a lot of different ways. Okay. And I don't think the students are taught in a different way from in US. I think our education is equally at par with the education that I got in my medical college. So I don't think so. I think it's the same. Yeah.
Right. And I guess there are many questions for Dr. Modak. What's the difference between psychoanalyst and psychologist and psychiatrist? Reading many books, but not being able to draw a line of differentiation between them. Okay, so Dr. Modak will be reaching out by email to individually, I guess. Are there more general questions from anyone else?
That's not what I meant. For some other questions, there's a lot to say. So I just try to be as brief as possible. As far as diseases are concerned, not everything is a disease. So a psychiatrist is a person who treats when you have a sort of a disease. Any disease can be treated with medicines, with some sort of a therapy. So as far as a psychiatrist is concerned, he's overall in charge of the patient. He prescribes medicines, prescribes the therapy, and it's generally the psychologist who administers the therapy, because it's about the best distribution of resources. Psychoanalysis is a field of psychology that was started by Freud, and Carl Jung was his follower before he fell out with him. It's not a very popular field of psychology right today, because people find that it does not lead to very good results. So that's the basic difference between psychoanalyst, psychologist, and a psychiatrist. Yeah. Regarding the second question, well, how has KPPY helped me? KPPY is, as far as I understand the program, it's been 11 years since I was part of the program. So as far as I understand it, KPPY is just a medium for you to expand your career. So KPPY offers those summer internships. So every summer, I used to call them up and I said, I want to go here. Can you just please call these people, write a mail to them, allow me to visit their labs, see what's going on in the most advanced labs of our country. So that's all it helped me do. So for example, once I went to this genetic engineering lab in IIT Mumbai, and there I learned that even pipetting has a skill. So you have that pipette and you press the plunger and you are supposed to take out 300 micro ml or whatever micro ml you have set in that machine. But I tried to do it. My guide said, you try to do it. So I found that 300 ml plus 300 ml was not equivalent to 600 ml. Either I was taking out more, or I was taking out less. So, any field of work has some basic skills. So you can use your KVPI. I don't know if they still open doors, but in my time, they used to open a lot of doors. You can explore various subjects, the work that is being done, especially AIIMS has a good program of summer internships. So faculty accept KVPI scholars. So you can visit their labs and you can see what is the kind of work that is being done and whether that interests you. The way it helped me is I realized that these don't interest me. This is what I want to do. So that's all that you can get.
So Amurtha wants to do biomedical device research in India. How can he do that?
Well, there are a number of startups who are trying to make biomedical devices in this country. The startup scene in India is really quite good. That's one way you can do it. And you don't need anything more than your MBBS degree. I mean, as far as the people are concerned, if you have the idea, if you have the skill, and it doesn't matter whether you're an MBBS, you are an MD, or you are an TM. There is a program run by the Department of Biotechnology. I forget its name, but they have 7 incubation hubs across the country. The nearest one to Calcutta is in Bhubaneswar. So you can apply to this program, and if your idea is good enough, you will get some amount of seed funding from the Government of India. That's some other research, some other avenue that I know of.
All right, thank you. So if you have more questions, you can post them, or if not, we can probably call it a day. Thank you once again, Professor Mukhopadhyay, Dr. Modak, and Dr. Sengupta. Do you have any closing words, any of you, or all of you?
I'm sorry, it was great interacting with the new generation. So,
thank you. Dr. Mukhopadhyay?
Yeah, I thank you for organizing this. And if anybody has anything to ask or anything, just shoot an email. Yep.
Thank you. And I guess the person in this room who we should reach out to if you are ill, actually, who will be of the most use in this group seems most to be Dr. Ananya Sengupta. So ending words from you, parting words.
Well, I think this was a very enlightening experience. It was nice for me as well, because I've not really been so much into the research scene. I've been more into the clinics, a bit of clinical research maybe, and it was an enlightening experience for me itself. And so I'm sure it would have been a great one for the young scholars as well. I think it's a great initiative. It is something which we lacked during our days of JBNSTS scholarship, as Tamonud would agree. I think Tamonud and I have actually interacted together a bit during our JBNSTS days as well. So I think this was something we lacked then, and somehow I think this COVID situation has thrown up new challenges and opened up new avenues as well. So yes, it's one of the benefits, and it's a nice thing, and I hope you carry it forward.
Thank you. Thank you. All right. So have a good day, everyone, and we'll definitely reconvene some other time.